Thank you for joining us tonight for tonight's program, COVID-19, the Medical Divide, where we will be discussing on this most tragic day where we've marked the passing of more than 500,000 Americans from the pandemic of COVID-19. We will be discussing how COVID-19 has impacted communities of color disproportionately and what can be done about it. We are very pleased today to have us for our moderator for this evening, Eileen Kwan. She is the Director of Marketing for Martin Luther King Jr. Community Hospital, as well as an award-winning healthcare marketing strategist, executive producer, and renowned host of a digital series. So without further ado, I'd like to turn it over to Eileen. Thank you.
Thank you so much, Charlie. It's wonderful to hear from you, as always, and to be joined by our esteemed panelists, whom I will introduce very shortly. Again, as Charlie mentioned, my name is Eileen Kwan. I am the Marketing Director of MLK Community Healthcare. And as we round this corner and 1-year anniversary, really, of COVID-19, we have weathered an unprecedented pandemic together. In the same vein, we have also made extraordinary progress in the last several months. I can speak just briefly on all of the work that we've done, not only from a MLK healthcare system perspective, but also just personally as a representative of the Asian American Society. I feel personally invested in this particular topic today. So as Charlie mentioned, with the rollout of the COVID-19 vaccine in its early stages and the possibility of an end, a foreseeable end to this global pandemic we're living in, it is hard not to acknowledge and address that there is a huge issue that has persisted even before the pandemic. And that really is the disproportionate effect of systemic barriers to healthcare access and education that have really propagated communities of color. So the challenge ahead of us now is really, how do we equitably distribute the vaccine and truly reach out and connect with communities of color to overcome vaccine hesitancy and address barriers head on. So obviously, most of these barriers won't be fixed overnight, but we can begin making progress by leading through example and through discussions just like this that you are joining us today for. So I would like to also take this moment to acknowledge each of you, our viewers. I know we have approximately 200 to 300 folks tuning in live, and those viewers include business leaders, students, and advocates directly from our community. And beyond hearing from our esteemed panels, again, this is your opportunity to really join us and ask our leaders, how do we really address the issues that are ahead of us today? How do we bridge the medical divide and tackle head-on health equity issues that we feel and see day to day? So with that, I'd like to go ahead and introduce our esteemed panelists, beginning with Dr. Michelle Ann Williams. Dr. Michelle Williams is the Dean of the faculty at Harvard T.H. Chan School of Public Health, and she's also a professor in public health and international development. She is internationally renowned epidemiologist and a public health scientist. And not only that, an award-winning educator and widely recognized academic leader. So with that, thank you so much, Dean Williams, for joining us today. Just a little wave works. It's good to see you. Thank you. Leading into our next speaker, Dr. Elaine Batchlor. Dr. Elaine Batchlor is the Chief Executive Officer of Martin Luther King Jr. Community Hospital, which opened in 2015. Dr. Batchlor was the driving force behind the effort to open our new state-of-the-art community-oriented safety net hospital and with a true focus, a true sincere focus on delivering compassionate quality care and improving health outcomes for the South LA community. So Dr. Batchelor, thank you so much for joining us. And last but not least, Connie Chung-Jo. Connie Chung-Jo is the Chief Executive Officer of Asian Americans Advancing Justice, Los Angeles. And that is the nation's largest legal and civil rights organization for Asian Americans, Native Hawaiians, and Pacific Islanders. Thank you so much, Connie, for joining us today. And now with that, I do want to go over some quick housekeeping items. We will be reserving some time at the end of this discussion just for your live Q&A. So I'd like to take this opportunity to point your eyes down to the bottom of the screen and go ahead and click that Q&A box if you are inspired or there's a discussion point you'd like to have elaborated on. Please go ahead and chat us and we'll do our best to screen and get those in the queue and submit those questions live to our speakers. So with that, why don't we not delay any further? Let's kick off our discussion with a few opening remarks. Dean Williams, I'll go ahead and start with you first. So Dean, first of all, hello. Thank you so much for joining us from Boston.
Thank you, Eileen. I have to tell you, it's a real privilege and an opportunity to participate on this panel with such esteemed colleagues. And I also want to thank you for framing the conversation, because as we think about the last 11 months, where we've been, how far we have to go, and the painful lessons learned, I resonate with a statement you said, and that is, this is a time where we have to reckon with how we ended up where we are over these last 11 months. And I'd like to frame my initial comments in three ways. One is a reckoning has to take place for us to really understand how we can build back better and work as a collective to avoid the kinds of crises and shocks that we have all experienced over the last 11 months. So the first thing I will say is the last 11 months was characterized by the pandemic, a biological shock to our system, but it was also followed almost immediately by an economic shock. The pandemic bringing us all to a full stop in our economic life. And then we all, because we were sheltering in place, most of us, witnessed in the most painful way the last 8 minutes and 49 seconds of an African-American man's life, George Floyd. These three shocks, a biological, an economic, and a societal social justice shock, has landed on us in a very profound way and an enduring way that, unlike other shocks like Hurricane Katrina or an oil spill, has had on our public health system, and our way of thinking about ourselves as a nation in the world. So let me begin by talking a little bit about what we reckon with as a public health leader. As a public health academic, I have seen now many more people come to try to understand what is public health, understand why it's important to invest in public health systems, infrastructure, and a workforce that is designed to protect, promote, and preserve health. And if we avoid protecting, promoting, and preserving a public health system and a workforce, we run the risk of multiple additional pandemics. And so there is a greater awareness now than ever that in overlooking and underinvesting in public health, we have gotten to a place where we now have seen the consequences in human lives, in our economic security, and our national security. The societal shock was in large part recognizing that century-long, century-old inequalities and injustices undergird the health disparities that we have been seeing pre-COVID and helps to explain why we saw a high burden of disease transmission, hospitalization, and mortality among color populations such as African Americans, Latinx, and Native American communities. And we had to come to reckon with why we were seeing this disproportionate burden borne by populations that are Black, Brown, and Native American. That reckoning has made it very clear that the systemic lack of access to healthcare, food insecurity, housing insecurity, livable wages drive an underlying high risk of chronic diseases that during the time of pandemic only increased vulnerabilities. The fact that these communities are limited in access to testing early on in the pandemic allowed for community spread to go undetected and unaddressed in a population that we later realized were essential to our economic well-being, in stocking our shelves in grocery stores and driving our buses and delivering our packages. And so what this reckoning brought for us was that we are deeply interconnected, that our inattention to systemic inequalities contribute to a weakening of the health systems for African American, Latinx population, and Native Americans in ways that if we don't pay attention to this, not only are those communities impacted, but all of our communities are impacted. And that reckoning of interconnectedness was important. And then finally, I would say this is critically important, is that our systems that support our communities, a discoordinated public health system, underfunded health system, contributed to this. The fact that most of health levers are outside of the healthcare system, but in places where people live, work, learn, and play, became a very vibrant, very important message for all of us to manage. It's not just in the hospital setting, but 90% of our health and wellness, those factors are outside of the healthcare system, and we have to build back social safety nets that protect, promote, and preserve health.
Thank you so much, Dr. Williams. Speaking of social safety nets, I for one am very happy to go ahead and introduce my leader and our hospital and healthcare systems leader, Dr. Batchelor, and invite you to respond and also speak to our current COVID challenges in the hospital. So Dr. Batchelor, I go to you, hearing about Dr. Williams' note on this reckoning, if you will, that we are all gripped in right now in our reality. Could you please give us a snapshot of where things stand at the hospital today and how the medical divide is really manifesting itself in the work that we're doing as a mission-driven hospital?
Yes, thank you, Eileen, and thank you, Dr. Williams. That was a perfect summary and framing of the issues that we've been dealing with through the COVID pandemic. And I am going to show a couple of slides that highlight exactly what Dr. Williams was talking about at the community level. We are a community of over 1 million people in South LA that includes Watts and the city of Compton, and a very low income community that is primarily people of color, Latino and African American. Los Angeles has been called the epicenter of the most recent surge of COVID, and we've been characterized as the epicenter of the epicenter. So the first slide on the screen highlights the fact that our small community hospital in South LA, we're a 131 bed hospital, which is a very small hospital, has had more COVID patients than most other hospitals in our region. This slide shows the percentage of COVID patients per licensed hospital bed in a 15-mile radius around our hospital. And what you'll see is at the very top, Martin Luther King Jr. Community Hospital, we had the highest percentage of COVID patients. We also had the highest number of COVID patients from across many hospitals, including much larger hospitals like UCLA Ronald Reagan Medical Center. Next, part of the reason our COVID census was so high is because our community has been disproportionately impacted for all of the reasons Dr. Williams mentioned. It's the home of many essential workers who were not able to isolate when the COVID pandemic hit. They had to continue to work. They worked in our grocery stores and transportation, in cleaning up after the rest of us in many different sectors, and continued to be exposed to COVID on the job. Many of them live in crowded housing where it's difficult to isolate if a family member gets sick. And we've seen many families coming in, all affected with COVID pretty much at the same time. They also are a community that has a disproportionate burden of chronic illness. Can you please advance to the next slide? One more. These are some of the disparities that impact our community. As you can see, we are missing 1,200 physicians in South LA, and we have the lowest number of hospital beds per 100,000 people in Los Angeles County. That has led to a lack of access to primary care, specialty care, almost any kind of healthcare you can think of, and an epidemic of poorly treated chronic illness. So I'm highlighting one chronic illness here that is very prevalent in our community, and that is diabetes. The prevalence of diabetes is 3 times higher than in the rest of the state, and diabetes mortality is 70% higher. As a result of this epidemic of chronic illness, life expectancy in our community is 10 years shorter than the California average. Our community suffers from all of these social determinants of health that Dr. Williams mentioned: limited access to safe housing, high rates of homelessness, lack of access to healthy foods, lack of access to transportation, poor education systems, and lack of employment. Next slide, please. So this slide shows you what we as a hospital and health system are seeing on a regular basis. This is, even before COVID, this is what we were dealing with. The majority of our patients, as I mentioned, are Latino and African American. 36% of our patients are admitted with diabetes. Our top surgical procedures are diabetic amputations and wound care. You know, think about that for a minute. And dialysis access is another one of our frequent procedures. This is for patients who have end-stage kidney disease, usually as a result of poorly treated diabetes, hypertension, and other diseases. The majority of our patients are publicly insured, 87% through Medicaid or uninsured. And you can also see that we have high rates of behavioral health conditions and homelessness. Next slide. This is what our COVID population looks like. So in 2020, we had cared for over 3,000 COVID patients. 82% of them had at least one chronic condition shown there, and 56% had 2 or more chronic conditions. One of the interesting observations about our COVID population is that it was disproportionately Latino. So under non-COVID conditions, a little over 50% of our patients are Latino, but we've seen 80% of our COVID patients are Latino. And again, it's a reflection of the fact that they're essential workers, they live in crowded housing, and they have a burden of chronic illness. One of the other interesting observations is that the percentage of COVID patients who lacked insurance is higher than we would normally see at a baseline. And I think that's partly a reflection of the higher Latino population. Next slide. So this is the last slide I'm going to show, and it's really a summary of some of the actions we need to take to improve health equity and make sure that we're in a better situation should the next pandemic arrive. The first thing we need to do is invest more in infrastructure and payment for community-based care. And following Dr. Williams' comments, I will be adding public health infrastructure to my slide, because public health infrastructure is also incredibly important and weakened in our community. We need to reduce variation in payment across payers and insurance programs. We have what I call a separate and unequal system of payment for healthcare in our country, with commercially insured patients at the top tier, Medicare insured patients in the middle, and Medicaid and uninsured patients at the bottom. In California, the Medicaid program pays approximately half of what Medicare pays to providers. And that's one of the reasons healthcare infrastructure in our community is so lacking. We also need to integrate medical and behavioral health care. It is very difficult to treat chronic obstructive pulmonary disease that's caused by substance abuse if you're not also able to treat the substance abuse. We need to address the social determinants of health that we just talked about. And finally, we need to increase the diversity of our healthcare workforce. And I think that that last recommendation around diversity also feeds into the next phase of the COVID pandemic that we're entering, which is trying to get everyone in our population vaccinated. We know that our community has a lot of vaccine hesitant members, and that relates to distrust of government and distrust of institutions like healthcare institutions. The more we have representation of people of color in healthcare, the greater the trust and the more likely we are to convince everyone to get their vaccines. The workforce at our hospital is over 80% people of color. We have vaccinated 1,500 of our healthcare workers and about 850 elderly family members. And we're now rolling out into the community to begin vaccinating there. So I will stop there, and you can turn off those slides. Thank you.
Thank you so much, Dr. Batchelor. I couldn't agree more that really there is no more pressing call to action than to really address what is the underlying issue. And here you've so elegantly illustrated that it's social determinants of health and very much the infrastructure piece of our health system, of our social economic systems that are really driving a lot of the narratives today. So I think that's a great segue actually into Connie. I'd love to hear a little bit about you and your work being in the trenches, directly serving our minority communities to make sure they get adequate healthcare. I know much has been reported about higher incidence of COVID and poor access to care for Black and Brown communities. But I would also like, just personally, I would like to know, what are you seeing in terms of the Asian communities and the diversity within the API community that's posing potential challenges or obstacles to access? I know that was a long-winded question, but I know there's quite a bit of interest. I'm seeing several questions pop up in the feed right now, specifically addressing this. So we'd love to hear from you.
Sure, thank you, Eileen. And just to first give a little bit of background about Asian Americans Advancing Justice Los Angeles, we are a legal service and civil rights organization that serves the Asian American, Native Hawaiian, and Pacific Islander communities. And I will say that we have a health access project that was started when the Affordable Care Act came out to ensure that all APIs, or Asian Pacific Islanders, had access to coverage. But since then, most recently now with the pandemic, we have been focused a lot in ensuring that API community members are getting tested and now getting vaccinated for COVID-19. And we have partners through our Health Justice Network all over the state to work grassroots with different organizations to ensure that we're able to reach our very diverse community. So when we talk about being on the ground and what that looks like for our Asian Pacific Islander community, I will start with that and talk about the fact that this is an incredibly diverse community, and it is very challenging and resource intensive to reach us for the vaccine. We are the fastest growing racial group in the country. We are the fastest growing immigrant group in the country. We are more than 60% foreign born. We have the largest percentage of people who are limited English proficient of any racial group. And I think what's the most challenging is we have more than 40 API ethnic groups in the country who speak more than 40 different languages. And these languages don't cross the board. If you are Korean speaking, you cannot speak to somebody else in Japanese. It doesn't work that way. And so what that means is in order to educate and outreach to the community, you need, and to do it in language, you need different people who are bilingual and bicultural to penetrate each group. So the language diversity is incredibly difficult. I will also mention that the community is very diverse in terms of education and economic standing and our immigration background. So whereas the Korean American community, when they came in historically in the 70s and 80s as professionals, same thing with a lot of South Asian Indians came here as physicians, that is very different than the history of the Vietnamese and the Cambodian community that came here as refugees. And so right now we're looking on the ground at how do you reach Vietnamese seniors who are limited English speaking, low literacy rate, low tech rate. And what our community partners are doing in order to get vaccines to this particular community is that they need to translate everything in language. Then they need to set up email addresses for each patient because a lot of them don't have that. Then they need to get them tested. And if there are things like results that you need to get back and they're sent by email, they need to help them access it, read it, and translate in language. So, you know, the practical challenges, the language challenges, and then on top of that, I would say there are cultural challenges. And I'd like to bring up a slide right now, please. One of the issues that we're seeing right now, and I think a lot of people have heard about it, is the rise in anti-Asian discrimination and hate as our community has been scapegoated under this pandemic. Certainly, it did not help that we had a previous president who used terms like Kung flu, China virus, Wuhan virus. But unfortunately, even as of 2 weeks ago, we saw a slew of Asian hate crimes and unfortunately the death of one Asian American, and it's been targeting a lot of the seniors. So if you could go back to that slide, please, there have been over 3,000 incidents of anti-Asian discrimination and hate reported across this country since the pandemic began. And if you look at the groups who are targeted most, it's Chinese, followed by Korean, Vietnamese, and Filipino. And I mentioned that the seniors have been targeted, and I will say that it's always the vulnerable community members who are targeted, our seniors, women, and those who are limited English speaking, because they're going to be less likely to report it or stand up for themselves. What this has done is that there is some fear of retaliation and attacks that make we are worried about trying to get our communities to come out there and get vaccinated, because some people are right now quite simply scared to go out of their houses. They're afraid of being attacked. So that is one of the challenges that we are dealing with right now, on top of the tech challenges and other language and other barriers like that. If you would turn to the next slide, another thing that I would like to highlight is that often we talk about, we want to talk about the Asian Pacific Islander community, but actually the Pacific Islander community gets left out of the discussion. And I would mention that Pacific Islanders actually have some of the most the most challenges, and we talk about the social determinants of health, and we see that a lot of those apply to the Pacific Islander community. If you actually look at LA County, the previous census data, the ethnic group that had the highest poverty and low income rates were actually the Tongan community, which was 75% low income and 51% lived below the poverty line. These are extremely distressing numbers. And when it comes to COVID-19, what we've seen is that although Pacific Islanders represent 0.4% of the county population, they account for 1% of COVID-19 deaths. So, and this is actually one of the highest rates of death within the racial groups in LA County. When you look at the total vaccination rates, what you see, and this is from a February 2021 report, that we have about half of those vaccinated reported for in this numbers that I have, but that of that percentage, 5% of those vaccinated are Asian American, and under 0.1% are Native Hawaiian or Pacific Islander. You compare that in this pie chart to what are those groups population size in LA County, and you see Asians are 5.6 and Native Hawaiians are 0.2, excuse me. So it's not too bad in terms of the penetration rate for vaccinations, but I do think that the very high rates of deaths in the Pacific Islander community really underscore some of the socioeconomic challenges that community has had, and some of the other things that were already alluded to. So I think what I would finish my opening remarks with is going back to something that I think Dr. Williams really framed it so nicely about connecting the pandemic with the economic disparities and poverty with systemic racism in our country. And I think it is hard to, you really can't separate those when we're talking about vaccinations. And I think when we talk about our Asian Pacific Islander community as well, and you look into it, I think it's important to remember that the community is extremely diverse. We are not a monolith. And although there is still this model minority myth, which is this preconception that all APIs are doing fine because we're all so successful and we're all wealthy and professional, I think the reality of that, when you really start digging into the numbers and you start disaggregating the data, which we always advocate we need to do more of, is you really start to see these kinds of disparities.
Thank you so much, Connie. I think that there is no more pressing issue than understanding these subtle nuances within the API community really are a huge indicator of how our community is faring in this pandemic. I would like to ask a follow-up question because, separate but unequal, this concept or catchphrase, if you will, is truly what we're dealing with across all minorities. So I'm curious, is there an opportunity to address the structure or the legal system or the policy from your professional perspective? And what can be done by lay people or by advocates in the community? What action can we take today to address these issues?
I think for me, when I look at what can be done and what lay people can do today, so I have to say, my mind has really been around what's been happening with hate crimes and incidents in the Asian American community, because that's been what's on the forefront of issues in my mind. And I've been asked a lot, what can we do about it? And I think it applies here in the same way when we talk about the medical divide, is that I think communities of color need to be in allyship with one another to fight a larger systemic problem of racial injustice in this country. Unfortunately, what you sometimes see is wedging of certain communities against the other. And we've certainly seen the Asian Pacific Islander community pitted against Black and Brown communities before, historically in our society. And we can't allow that to happen. We have to recognize that really in what has been, when we talk about systemic racism, we're in a white dominant culture. And that it is the job of everyone to be allies to one another, to address and dismantle that disparity that comes, I think, is underlined by systemic racism, by not allowing us to try to fight against each other and compete for resources, but instead work together to expand the pie for all of us. So, I think it's come up a lot right now, because when you look at what happened, as I think Dr. Williams said, with first the pandemic, and then that's when we first started seeing the targeting of Asian Americans and the rise in discrimination and hate crimes, and followed very soon after with the murder of George Floyd and the Black Lives Matter movement and the reckoning around systemic racism and anti-Blackness in our society. It gave us a chance to see in a very short time frame how discrimination has impacted two different communities. And I'm not saying that we've been impacted in the same way, but I'm saying that we have to recognize that there is a system that is bringing all of us down, and we need to be advocating for one another as well as each other to ensure that we address these disparities in the medical side, with COVID vaccination, and I think in so many other areas.
Absolutely. And Connie, I think that's an incredibly hard question to answer, right? When we talk about prospects for allyship and tying together these disparate communities to improve healthcare for all, you can't say everyone's out to help themselves, but we really have to look at it truly as what a pandemic is and how it functions and how it moves physically throughout so many different communities. Pandemic has no boundaries, period. So I would like to open this up and also ask a similar question to both Dr. Williams and Dr. Batchelor. Feel free to respond and let's have an open dialogue. Back to the question around public-private partnerships, policy changes, what are concrete steps that can be done today to address some of these issues? Would either of you like to respond first?
Yeah, let me just thank Connie for her really brilliant response to your last question, because I think it's so important that we really recognize just how deeply interconnected we are, and how where there's a threat anywhere, there's a threat everywhere for everyone. And that's what COVID did for all of us. And so, inequity, whether it's vaccine nationalism or it's structural racism right here at home, it is a risk to all of us. And I think that's what this pandemic has made so clear for so many of us. In addition to the other things that we can do to really work to address the disparities that we've been talking about, is to make sure we have data. We need good information. What gets measured matters. What gets measured can be used to promote advocacy for social movement for change. And, as I listened to Dr. Batchelor's presentation about the unequal healthcare system, I can't help but think about the fact that, at the beginning of 2019, there were 30 million Americans without healthcare and health insurance. By the end of that same year, that number had ballooned up to 35.7 million. Wow. That is unconscionable, especially given the fact that the United States spends more money on healthcare than any other country on this planet. But we seem to get so little for it. And so we need to have better data. We need to have consumers be smarter about where our funds are spent, how they are spent. Only 2% of that money we spend on healthcare is for public health. If we really want to protect, promote, and preserve health, and to prevent some of those chronic diseases that have made communities of color exceptionally high risk for a pathogen like coronavirus, then we have to do better at promoting, protecting, and preserving health. We have to put money in communities where we can start to address those social drivers that drive up respiratory illness, diabetes, hypertension in these communities. And if we do that, we all benefit, because the truth is we're all paying for these structural inequalities now. And we have the resources, they're just misplaced. They're not in the communities. You know, before COVID, we were closed, health centers were going out of business. Community health centers were going out of business. Before COVID, inadequate access to quality healthcare was a problem and is still a problem. And think about it. We are now trying to do vaccination campaigns in communities where health centers have been closing or under financial stress and strain. We can do better. We have to have better data, and we have to have better value for the money we put in our health system.
I'm sorry, I was on mute.
Eileen, can I add a couple of comments to
Please
those
do.
that we've already heard? So one thing I would say in response to Connie's call to action for us to be allies and work together is to say that I think that we've just had an example of the success of all of us working together, and that is the election of a new president who has made a commitment to take the pandemic seriously and to address it in a way that will address both the biology and the need for treatment and vaccination and the economic devastation that the pandemic has wrought. So I think, I feel like that's a huge success starting right there. In addition to collecting data, which I was also going to say, I think we also need to tell stories that put a face on the data about the impact that these health disparities are having in our communities. And we really have to make it visible to the rest of our society what these disparities really mean. And then finally, a lot of the disparities are rooted in public policy. So that's partly what Dr. Williams was talking about. And, we need to advocate for changes to public policy. I spent the weekend reading this book called The Political Determinants of Health and who you are voting for, because the leaders we elect establish our policies and our priorities. And if we vote for the right leaders, we can start to make progress in how our resources are being allocated in this country and strengthen our social safety net and make our society more equitable for all, whether it's in healthcare or in social justice.
Absolutely. Thank you so much, Dr. Batchelor. I think we really hit the nail on the head. There isn't one easy answer. Needless to say, there's no easy answer, but we collectively need to think about how do we look at policy, how do we look at electing officials who are truly advocating for the interests of our communities, all minorities, and how do we really move the needle forward in the ways we can in our day-to-day. So I would like to take this moment to briefly transition to questions and answers. I'll invite the panelists also to open up that panel or window if you can see and skim through any of interest that you'd like to speak to immediately. I do know, let's see here. I do know that we've got a couple here. The first one I see here is it's a great question. It starts with, speaks to the issue of systemic problems that have been built over centuries. So the question is, what is a realistic timeline to get progressive leadership at different public and private levels to rebuild these systems, excuse me. I know that's a tough one, but
Well, I would
what's the
say
timeline?
it needs to start now. And, you know, a lot of progress is made in our country during periods of turmoil and stress. So we had the Affordable Care Act that came out of the recession/depression of 2008. Well, this has been just as large a disruption and impact as that. And I think that we need to seize the moment to talk about the underlying problems that need to be addressed and to push for those solutions.
Absolutely.
Yeah. And I would say, you know, you asked about public-private partnerships. I think what we are seeing now is the private sector is beginning to appreciate the important roles that they can play in addressing inequity. So when the city report, you know, identified that our inattention to racial inequity and discrimination, when they calculate that we've lost $16 trillion over the last 15 years because of racial injustice, and they put an economic price tag on this, as well as the moral, you know, concerns about inequity, you start to get investors, bankers to appreciate that the systemic racism and the undervaluation and opportunities for communities of color to raise wealth is a cost that is borne by all of us. And they will help and should help in making sure that we're on the right path to equity.
Absolutely. Thank you so much, Dr. Williams. I'd like to go ahead and use that as a launch platform to a question for you, Connie. The question really is, you know, if we look at health equity and we look at specifically the API population, you know, can we pinpoint a particular issue that is unique to a specific I'm sorry, let me back it up here. There are a lot of different, I would say, variables when it comes to the Asian American community or API community. You mentioned tech barriers or as well as a language divide. The question specifically is asking about cultural traditions or religion. Do we have that as an additional layer that we have to consider when talking about access or education for vaccines?
Yeah, I mean, you know, there's certainly other kinds of barriers, and I think I've heard in certain groups where there's a feeling that the religious leaders would discourage folks from getting the vaccine. We've unfortunately heard of some faith leaders and other community leaders from specific ethnic groups provide misinformation and the wrong information about the vaccine and say things like you have a higher chance of dying if you get the vaccine. There seems to be some stigma and shame for certain members of the Asian Pacific Islander community who have had COVID and feeling like they're going to be shunned for having had it, and they don't, and so wanting to stay out of the limelight. Certainly, we also have other things, like we have a lot of community members who are undocumented, and they are scared to go anywhere near anything that they think might be related to the government because they're scared of deportation. They're scared of, there's misinformation about what happens with the data if you go into a center and then they get your information. So there are many, many different challenges and barriers. And when you're working within this population or trying to address this community, one of the challenges is you really need to go deep, and you need to have people who are bilingual and bicultural, because it is a very different situation working with a Khmer speaking Buddhist refugee who survived the killing fields in Cambodia than it is working with an undocumented Korean American college student, and there's just who is Christian, because that's predominantly what Korean Americans are. So you have so many different nuances with these different groups, and that's why at Advancing Justice LA we have many partners on the ground we work with, because we can't expect that community members are going to be comfortable going to a Pan-Asian group. You know, they want to go to the Samoan group on the ground. They don't want to go to a Pan-Asian Pacific Islander group and assume that our organization is going to be able to support them. So I think that would be some of the challenges. If I could also just jump in, Eileen, to the last question about the timeline. I mean, I think the timeline is so hard because, you know, the history of systemic racism and disparities in this country is not a new thing, right? I mean, obviously, anti-Blackness has been going on since like the beginning of this country. When people hear about anti-Asian hate, some people think this is a new thing, and it's absolutely not. We've had the internment of Japanese Americans in World War II. The only law that ever explicitly excluded a group by their ethnic name came from the Chinese Exclusion Act in the 1800s. So the discrimination against Asian Pacific Islanders or any other group, the Latinx or the Black communities or American Indians, is nothing new. And so it makes it challenging. It is not a fast solution. But I think, as Dr. Batchelor and Dr. Dean Williams have said, we are seeing the time is now to make that change, because we have so much more of a understanding around this issue than we, I think, had, you know, for many, many years. You know, I came to this organization in August because of what I saw with anti-Asian hate and then Black Lives Matter movement. And it was not an easy time to switch jobs in the middle of a pandemic, but I was really inspired to want to come back into my civil rights roots because of what I'm seeing. I think we're seeing that all over the country. People have sort of woken up in this country and they want to get involved. And this is the catalyst for change. I think what we need to do is figure out how to channel folks' energy and continue that momentum. So how do we keep awareness going? How do we keep demanding that we focus on vulnerable and underserved communities for vaccinations? How do we keep demanding we have disaggregated data so we can see who is, where are the disparities, and demand that we have changes there?
Well, Connie, I think you just teed up our next question, and I'd like to volley that up to both Dr. Williams and Dr. Batchelor to respond to. And that is, you know, looking again granularly at the data, how do we identify COVID-19 hotspots in LA and throughout the nation? So the question simply is this: what is the best index to use to identify COVID risk and interventions for each of these disparate racial groups, be it Asian American, Black American, Latinx, Native American, Pacific Islanders? Is there an index to use?
Well, I think that we can look at the data first, and public health agencies have collected data on prevalence of COVID and census of COVID in different communities. It may not be entirely accurate because of differences in access to testing, but I think we can learn about the distribution of COVID through that data. We have our own data and we've produced our own maps. So as we think about how to go into the community and do vaccinations, we are really targeting what we call COVID hotspots, which are the communities in the specific geographic areas where most of our COVID patients have come from. So I would say that, you know, we already have the data. It's really a matter of really slicing it and dicing it so that we can see it, you know, by ethnic group in addition to by geographic area.
Yeah,
absolutely.
I would say that the geographic area is going to be really important, because in neighborhoods that are hyper segregated, those are de facto our hotspots. And one of the things that we have to insist on, and we haven't really seen this, is having race and ethnicity data for populations that have been vaccinated. We know that we had trouble with our underrepresented minority communities having access to testing. And still today, 11 months later, you know, 1/4 of Americans who need and want testing can't get testing. And we are seeing disparities in the vaccination in the states that are actually collecting data on race and ethnicity of populations being vaccinated. And so we have to be really thoughtful and careful in making sure that we're holding our local, state, and national agencies accountable for bringing forward as complete data as possible. So when there are disparities, like in vaccinations, in hotspots because of the high density of low wage earners, unemployed individuals, elderly, people who are immobile, we need to have those data to identify the vulnerable populations.
Absolutely.
Well, Eileen, I was just looking at a map. I don't know if I can share my screen or not, but this is the map that just came out of vaccinations in Los Angeles County. And there's a hole in the middle that is very pale. That means very few vaccinations around the communities of South LA and Compton. And it just really highlights what Dr. Williams just said, which is, this is a geographically driven both risks and access.
Yeah.
Absolutely. Thank you so much for sharing that. It is startling when I see that gap on my screen so wide. And really what that is really highlighting and illuminating the disparities in healthcare that perpetuate our community. I think what's so powerful about this conversation today, as we wrap up, is really that there's a call to action, if you will, a calling for all of us to continue to engage in these strategic responses to meet the needs of our community. So even when we turn the corner on disparities in health, we also need to continue to invest in outpatient care, which is going to keep building up the healthcare infrastructure that is so lacking, as you just saw on the screen, for underserved communities. So I do know we've just got 3 minutes left, and I do want to make sure I turn the baton back over to Charlie Coker. But before I do that, I just want to take a moment to applaud each of you and thank you so much for spending this time with us and engaging in dialogue. So thank you for being here today. Charlie, I'll go ahead and pass the baton back to you to wrap us up.
Thank you so much, Eileen, and thanks also to Dean Williams and Dr. Batchelor, as well as Connie Chung-Jo, for an amazing and important discussion. We'd like to thank our partners on this program, the Los Angeles Urban League. We've been so grateful to work with to highlight these issues in our communities of colors and to see how we can make a positive change in the world today. We also like to thank our promotional partners, Asian Americans Advancing Justice, as well as the Harvard T.H. Chan School of Public Health, the Harvard Club of Southern California, and MLK Community Healthcare. Before I sign off for this evening, I'd like to let you know we're going to be having a program re-examining the perception of realities in the U.S.-China relationship, which will be our next program on March 10th. And we will be having another program very much talking about many of the issues that were discussed today, especially vaccine issues, probably in about 3 weeks, and we will be announcing that at a later date. But again, thank you so much for joining us, and thanks to Eileen, as well as Dean Williams, Dr. Batchelor, and Connie Chung-Jo for an incredible discussion. We encourage you to become a member of Asia Society Southern California, or to donate to help support these programs. We make all these programs free to the public, and we would very much appreciate your support. So on that note, thank you and good night.